Hey, good day, everybody, and welcome to another great LinkedIn Live episode here at Advize Health. I'm really excited about this one. As always, I am still Eric Rubenstein, the Senior Director of Litigation, Fraud, Waste, and Abuse here at Advize. And, we do these monthly LinkedIn Live. We have different people on. We always have a fraud, waste, abuse, compliance spin. Today, I've got a great guy. I've got Eli Rushbanks. Eli used to be a member of the board of directors of an organization called $4. He is now an employee of $4's. Eli, $4 is a very near and dear place to us here at Advize. Jean Marie Loria, our chief executive officer, is a member of the board. We were introduced to Jared Walker, the founder of $4 a couple of years ago. We've always felt here at Advize that it is important to reduce the cost of healthcare, and that is something that Jean Marie is very passionate about. She was introduced to Jared. Somebody had sent over one of the first videos that Jared had done. It went viral. Something like 100 million people around the world have now seen it. I think at the time, 50 or 60 million had seen Jared's video where he talks about reducing the cost of healthcare through getting people in charity care. Jean Marie reached out to Jared and has since now become a member of the board. And, $4 is a great organization. So I want to turn it over to you for a couple minutes. I want you to talk a little bit about who you are, your background, what you do at $4, and then really what is $4 as an organization.
Yeah, thanks. I'm excited to have this conversation. So Eli Rushbanks, I am a lawyer at $4. I'm the general counsel and the policy director. I first got involved with $4 probably was 2017 or 2018 when I met Jared. I was in private practice doing consumer protection litigation, representing people who were being sued for a debt, oftentimes a debt that they didn't owe, and that got me into the charity care laws, both in the states that I practice in, which is Oregon and Washington, but also federally as it relates to nonprofit hospitals. And I got introduced to Jared because we were both kind of the medical debt guys in town. And at the time, $4 was more of a crowdfunding organization where it raised money and then paid off people's medical bills. Jared wasn't even paying himself at the time. It all went to the patients. And I told him I could start helping out, taking pro bono cases, doing some charity care applications, appeals if need be. And shortly after that, he asked me to join the board, and we kind of shifted the direction of the organization to be more charity care focused. And then Jared decided to go viral on TikTok, and we got flooded with applications from across the country, got connected with Jean Marie and a ton of other folks who've been super helpful to $4's success to date. So today, what $4 does is we kind of have two sides of the house. There's the direct patient work where we directly help patients with charity care applications, and I can get into what charity care means in a minute. We also have a bunch of resources on our website if people want to go through what we call the self-help track, where they can use our resources to advocate for themselves to try to make their medical debt go away. And then the other side of the house is more my day-to-day, where we're moving upstream in kind of the billing cycle, where we're trying to get hospitals to not send patients bills that are charity care eligible in the first place. And we're working directly with hospitals to see if we can get them to change practices internally, change provisions in their policies. And we're working with state regulators. We're working to support different bills and different advocacy efforts that we can do in states across the country. So I think that's a rundown of me. I don't know if we want to get into charity care in detail at this point.
Yeah, so we're gonna. So the thing that I've always found interesting is that the amount of red tape and bureaucracy that exists in getting people qualified for charity care is sometimes a challenge. Now, for our viewers, sometimes they don't understand what exactly that means. And so from a regulatory perspective, there's something called disproportionate share hospitals, or DSH payments. And that is, what people don't necessarily realize is that's an HHS funded program that comes out of CMS. And basically what happens is that states get a chunk of money that they then dole out to different facilities, hospitals around the state, to ensure that the uninsured or the underinsured are provided with care. Because there is a statute called EMTALA, which is essentially also known as the Patient Dumping Act. And it essentially says that a hospital cannot turn away a patient in need of critical care, that the facility must stabilize the patient before transferring them out. And there are a ton of cases out there. When I was an OIG agent, I worked a lot of those cases. You would see in very large urban settings, patients are sometimes sitting in waiting rooms for days on end, and then the patient just isn't given the kind of care that they should get. And so for the viewers who don't understand what this is that hospitals get a percentage, they get a dollar amount based upon the aggregate amount of money that the state gets, and it is based on a number of factors. One is the percentage of patients that they treat in a given year, the prior year, that are uninsured or underinsured. And so obviously your hospitals that are urban, that are in difficult access to care areas and the like, are going to get the most money, right? So in the state where I worked for many, many years in New Jersey, University Hospital in Newark was the #1 hospital to get money. Cooper University Hospital in Camden was one that was, pretty much on the hit list, because you've got a very large urban centric population of people who have no insurance, and so there is a requirement to provide them with care. Charity care is essentially the name of the program that the hospital must institute in order to be able to provide people who would qualify to get their hospital services for free or at a greatly reduced price. Eli, correct me if I'm wrong on any of this. I try to think I've gotten it mostly right.
You nailed it.
Yeah. So these are important. And so where $4 comes in is there is a population of patients who would theoretically qualify to not have to pay for the care that they get, meaning the bill. And hospitals oftentimes don't have enough information on the front end to qualify a person for charity care. But then on the back end, when the bills come in, the patient now is in a position to potentially qualify for charity care. And what $4 does is kind of help that process out. So talk a little bit, Eli, about like, what is that process? And what are some of the challenges that people encounter along the way?
So it can be the process can vary by hospital. So big picture, hospitals that are nonprofits, 501c3 nonprofits, are obligated to do this for the benefit of being a nonprofit, for not paying taxes. So came out of the Affordable Care Act, there was 501R, the tax code, that said if you're going to be at a 501c3 hospital, you have to have one of these charity care programs in place. But it put very few parameters around what that must look like. So hospitals have to have some sort of policy. It has to generally be targeted to people who can't otherwise afford care. And that's broadly it. So some hospitals will require almost every hospitals we see require the patients to bring it up and apply. So there's almost always some sort of signs in their lobby, which is one of the few requirements. They generally will have some sort of language on every bill that goes out, but it's in terminology patients don't understand. They say, if you want to inquiry about financial assistance, capital F, capital A. I mean, I can tell that some lawyer drafted this using the defined term from the law that doesn't actually resonate with what this is for people, which is a discount based on that they're entitled to by law based on income. And so if the patient finds out about charity care in the first place, they usually have to fill out an application that is almost always a paper application that you can get from the hospital reception desk or print out from online if you can find it, because they're often not on easily navigable websites, and they're usually buried on a 400 or 500 page website. So if you find the application, you fill it out, there's generally proof of income requirements, which in easier hospitals, that could be as simple as a W-2 or a most recent tax return, or both, for every household income earner. And in more difficult application processes with hospitals, I've seen hospitals require people to print out 3 months worth of bank statements and write a description explaining any transaction exceeding $100. We've seen hospitals require anyone who's unemployed to get a letter explaining how they're supporting themselves from either their pastor, lawyer, or doctor. There are all types of requirements that hospitals can put in place because of the sort of vagueness that they can slip into in 501R. So that paper application, once you can get all these documents rounded up, depending on what those might be, which are going to be described in a 7 or 8 page policy, again hidden on the website and in legalese somewhere. That's usually going to have to be mailed or faxed back into the hospital. If you're lucky, there's an email, and if you're really, really lucky, there's a mobile-friendly online application. The mobile-friendly online application is exceedingly rare. I can't even actually think of one. I'm sure we've encountered them, but every once in a while, maybe, I don't know, totally incorrect estimate of maybe 10% of hospitals have an email that you can send it to. Otherwise, you're trying to get your hands on a printer, printing this thing out, faxing it in. So that's what $4 does. We've aggregated all of the rules into a single database for nearly all the policies across the country. Every once in a while, we find one that we don't have in there, and we add it. And then we will handle that totally for free to patients. The helping them gather the application, getting the application documents, getting the paperwork together, and then we can go ahead and fax it in or mail it in or however that needs to get to the hospital. And then we will stay on the hospital for the weeks or months or sometimes over a year that it usually takes, because it's very common that they claim to not have received the first application. And they usually, and most of the time they say you'll receive a response within 14 days. I don't know if I've ever actually seen that happen. It's usually closer to 6 months if you stand on them. So that's kind of this is the benefit that hospitals are offering to patients to receive the billions in tax benefits.
Well, so a couple of things to unpack this. I mean, the first thing is that to say that this is a benefit that hospitals are offering, it's really not a benefit that hospitals are offering. It's a federally required regulation that is funded by HHS to do it. So it's not like charity care is a hospital's gift back to a patient who is in need of needed medical care. It's a federally mandated requirement that works in conjunction with things like EMTALA and things like that. So, but I talk to Jared pretty frequently because I obviously am interested in the fraud, waste, abuse, and compliance hook. And and you brought this up, which is that you sometimes might have to fax the information in. And and I think this is it's almost humorous that the indigent population in this country are sometimes the working poor. They don't qualify for Medicaid. They're the working poor, paycheck to paycheck, and they're literally living off of their cell phones, right? They don't have access to the kinds of things that other people have. So they don't have printers, they don't have fax machines. And so when a hospital says, well, you can apply for charity care, and obviously, and I've seen this when going to hospitals myself, that the challenge is that a hospital doesn't say right off the bat when you show up, you say, well, do you have insurance? No. Oh, do you may qualify for charity care. There's no affirmative discussions, right? It's responsive discussions. And so, from my perspective, that to me is where a tectonic shift needs to occur, is that there are a population of people that need to be able to qualify that don't qualify. So before I get, because to me, I see a huge fraud, waste, and abuse component that you guys don't deal with because that's not what your thing is. But $4's existence is solely based upon the charitable contributions of people and companies. And I know Jared pounds the pavement. He goes to conferences to speak, and it's all based upon the charitable donations of organizations of people. The theory initially being that if I got charity care and my payments were now crushed, that I would put $1 forward for doing that. So talk for a quick minute about the fact that as a 501c3 organization itself, that $4 it exists solely on that, and how that money comes in.
Yeah, we live and die by donations. Like you said, we don't charge patients. We're not going to charge patients. There may be other revenue models that might pop up one day for $4, but right now Jared gets out there and tells people about what we do, exactly like what you said. The largest source of funding for us right now is foundations. We get I think I shouldn't say the numbers because I have no idea, but it's more than half foundation funding. Individual donors are great, and then when businesses can cut us those $10,000 or $15,000 size checks, those go a long way, because we have I think we're, as of this week, because we're onboarding a few more, have I think 8 patient advocates that are doing this full time with folks, plus the rest of the team that gets us up in the 14 or 15 range to do this. And we're still 20 or 30 Xing our donation. So for every dollar that gets donated, it kind of shifts depending on the year and how much debt we can get relieved. But it's generally $20 or $30. It generally corresponds with $20 or $30
Right.
in debt relief for people.
Right. Look, and I know that when Jared started this, it was, a few years ago when Jean Marie met Jared and I met Jared, he was working out of his house. There was no space, and he was still having a full-time job and kind of doing this, on the off hours and on the weekends. And I know that you still very heavily as a charitable organization still rely very heavily upon volunteers to help get this work done. The biggest costs, being manpower and the technology. So, but I do want to shift. I want to talk a little bit about, the fact that there are some studies out there where some studies have indicated that hospital bills, 80% of hospital bills contain errors. And when we're talking about the hospital bills and 80% error rate, what we're talking about is the fact that at the end of the day, are people paying for an item, service, or procedure that was billed or calculated or something in error? Now, one of the things is that you guys over at $4, you don't have clinical staff. You're not reviewing medical records. You're not arguing with hospitals about whether the bill is right or wrong. There are organizations out there, and I don't know how they all work, but there are organizations out there that buy the debt from the hospital and then negotiate it and do whatever that, they essentially buy the debt, negotiate and deal with it. And that's not what you do. You're negotiating with the hospitals to get patients into charity care. You're not saying, hey, Eric Rubenstein has a $5,000 bill. He could pay you $50 a month. You're not doing that. You're not working as a credit organization or a credit repair. You're basically saying Eric Rubenstein has a $5,000 bill. He can't pay it. He qualifies for charity care under that state law, and you should be giving it. But that doesn't take away the fact that at the end of the day, you're working to crush a bill that could have as much as an 80% error rate. And then, before we started our recording, I looked at some data that said as many as 25% of bills are errored strictly based upon typos in the bill. So there's a huge area of, we'll call it opportunity to fix these from a fraud, waste, abuse, compliance issue. And I just want to make it, clear that for people that are tuning into this, that's not what you guys are doing. You don't care if the bill is fraught with fraud, waste, abuse, and compliance issues. Your focus is, hey, this person should not have gotten this bill because they qualify to receive the charity care program that your state has implemented and then your policies, right? So this isn't a matter of fraud, waste, abuse, but it's clearly something that could be out there. You just don't really have it. It's not a dog in your fight.
Yeah, and it's, I would guess that there is probably far more fraud, waste, and abuse in bills that go to patients because there isn't that sort of natural filtering of fraud, waste, and abuse that would occur in the back and forth with insurance company payers or with Medicare and Medicaid payers, just because they're going to employ coders and people to review these things and give pushbacks on bills, which is not a skill that patients have. So yeah, we're not buying debt. I mean, when we make a bill go away, the hospital does not receive anything from us or from our patients for the percentage that we got it adjusted down. They may and should be reporting that to CMS as on their worksheet S10 in their charity care line item for sure. So they will get some DSH payments as you pointed out. But yeah, this is purely this debt it goes away and it is written right into the tax code that, hey, you're going to not pay taxes. You're not going to pay state property taxes. You're going to get billions of dollars in benefits. And one of the big trade-offs is you're going to give lower income patients breaks.
Yeah. And so, I think for people who get these bills, and maybe they're looking at the bill and they're saying, well, I don't remember having this and I don't know if I got that, right? It's very granular. You really need
Yeah.
to have an expert who understands clinical documentation and what they call clinical validation and documentation improvement. And, we have a team here of nurses who are on the payer side who do this. And it is a very technical job and it requires a level of support that you don't deal with. And I think that, I want to make sure that people understand that that's kind of a defining piece for you. You don't care about what the procedure, item, or service was that the patient got. You don't care how long they were in the hospital. You don't care about the medical records. Your goal is to get the hospital to comply with the state requirements and the federal requirements under the Affordable Care Act and help navigate those super deep complexities that are out there, which then presents its own set of challenges, right? When you've got people who are working poor. So what are some of the things that you're doing at $4 to educate hospitals to be, because I have to imagine that this is somewhat of an acrimonious relationship, right? Hospitals are given a limited amount of money under the DISH program, and they want to limit it as much as they can to not give it to everyone. But how does that relationship play out? And then secondarily, I'll give you the one thing that they tell you never to do as an investigator is ask two questions. But how do you educate hospitals? But how does that acrimonious relationship become a symbiotic relationship?
Yeah, well, one thing, and that I want to correct, and I need to correct myself because I said it too. Charity care is broader than just applying to what we might think of as the working poor or lower income folks. Most of these programs go up to at least like 400 or 500% of the poverty line, where there might be a 50 or 60% discount on your out-of-pocket costs if you're within that range. So you can have a family of four on over $100,000 a year household income and still probably looking at getting the bill halved or more. So that's one thing that I would, if Jared watched this after the fact, he'd be upset with me if I didn't say that. Regarding our relationship with hospitals, I don't. It often isn't and doesn't have to be a contentious relationship. And this is something that I have evolved kind of how I approach hospitals, because I think when I first got into this role, I do a lot of policy work. So we're working with state regulators, we're working with like attorneys general offices, and we're working directly with hospitals. If we think that they're doing something that violates federal or state law, we'll reach out to them directly, write them a letter, say, hey, we flagged this. We aren't going to assume you're doing it on purpose, but we'd like to see it fixed. And we've had hospitals take us up on that. There was a big hospital system, 31 or 33 hospitals, I think, that wasn't issuing refunds to people after it was right in their policy that they wouldn't issue refunds after they were found eligible for charity care if they had overpaid. And we pointed it out to them and they said, you're right, it's in the federal law that we have to do that. So they changed their policy and retrained their staff. They also agreed, and I don't even think that they had to, they just thought they agreed with us that it was appropriate to take all the information about their third-party payment plan product, which is essentially, in my view, a medical debt credit card, off of their charity care page on their website. They just moved that to a whole separate section. So people there for charity care won't get confused by what financial assistance means. So that's just one example, but we've had several hospitals we've brought a case to them and they've said, you're right, that we're not doing this right. We're not living up to our obligation. We'll change it. So that's nice. We've also had more hospitals that have done that have ignored my letters, and we're still working for solutions for that. But in looking at hospital financial data, I don't, if a hospital views me approaching them or $4 approaching them as trying to take something away from them, I think they're fundamentally wrong. The vast majority of money that we're getting into the charity care column is otherwise sitting in the bad debt column for hospitals. And we can see this in hospital tax filings. In their 990 that every nonprofit has to file, hospitals have to file a special document called the Schedule H that any provider watching this at a nonprofit hospital probably is very familiar with, where they have to report several things about their charity care program. But one thing they have to report is how much bad debt they have, and they also have to report how much of the bad debt do they estimate was eligible for charity care had the patient just applied. And oftentimes it's about 3/4. It's about 70 or 75% of the bad debt estimate was eligible for charity care. So when I approach a hospital and I'm trying to, we as the organization are trying to get them to approve a difficult charity care case, or I'm trying to get them to make their charity care program in general a little bit better for patients, I'm always pointing to that number to say, this is the number that we mutually agree on. And it's actually most of the problem, like is where, if you could just shift that over from charity care to bad debt, it makes no difference to you. You're not collecting this money anyways. And I think there's an accounting argument where they can report more of that for a DSH payment if it's charity care than if it's bad debt. So I'm trying to sell hospitals these days in conversations I have with them. I think they can make more money if they give more charity care.
Yeah, I mean, that's really the point, that at the end of the day, when a hospital is getting its disproportionate share hospital payment, it's reliant upon the previous year's dish amounts, number of patients they saw. So if you categorize it appropriately, you might be entitled to more money that you weren't getting the previous year, right? So it's not like it's creative accounting. Like, at the end of the day, if a hospital has a fair amount of bad debt, they're not paying taxes on bad, as a not-for-profit, they're not paying tax anyway, but it definitely goes towards where their payments are, certainly on their cost reporting to Medicare, right? Because under Part A for Medicare, hospitals submit cost reports every year, which is like a tax return, and part of that is all it all interacts with each other, right? They still need to submit for their Medicaid. They submit something called the CMS 64, which is the quarterly kind of payment schedule, and all of that kind of works together. So one would think that if you were appropriately categorized, 3/4 is a shocking number to me, that if 3/4 of bad debt is actually charity care, a hospital may actually be screwing themselves out of getting money that they would otherwise be appropriately designated to receive. Now, obviously, we know it's not dollar for dollar, right?
Mm-hmm.
It's not the same, no pun intended, but it's not the same. But the point being is that if you had appropriately put people into the charity care program from your facility, you would potentially be entitled to more money, or at the very least, a proper accounting for that money. So it really is shocking to hear that number from you.
Well, and that's not every hospital, but there's a significant number where it is around there, and every hospital calculates that number a little bit differently. None of that's standardized, but it's one way or the other. No matter how you cut it, and it kind of just lines up with common sense. A good chunk of every hospital's bad debt is eligible for charity care,
right?
And the argument I've been making to hospitals is even a little simpler. They can report both charity care and bad debt to CMS as part of their dish payment, but under the generally accepted accounting principles, bad debt can only be calculated on what they reasonably expected to receive. Whereas I don't see any reason they can't report the entire charge master rate on the charity care line item. So the exact same column, or the exact same the thing that was billed, I don't want to call it debt, but the exact same invoice can be reported higher to be reimbursed on if it's in the charity care column than in the bad debt column.
Yeah, that's super interesting. And obviously the premise also being that a suburban hospital in a wealthy community is going to have much less charity care because they're going to get a smaller dish payment or something. And I think the take home for me is that, and you brought this out very early on, is that this is all part of the Affordable Care Act. So when the Affordable Care Act was passed in 2010, it created a broader expansion of eligible people for Medicaid, because part of the issue was to get people who were underinsured or uninsured out of the emergency room where costs are exorbitant, right? Send people to urgent care centers, send them to primary care, send them to the local, the Minute Clinic type place, community health centers where costs are much less than an emergency room, right? You go to the urgent care center in your community and a cash visit might be $125. That same exact visit with the same level of care in an emergency room could be $5, $6, or $7,000. Now, that's not to say that that's not exorbitant. Obviously, it is, but a lot of these things, which whether you want to say that you agreed with the Affordable Care Act or not, there were pieces of the Affordable Care Act that, as we get further into it, and you and I have these conversations, and I have conversations, people should be having an aha moment that a lot of this stuff, as complicated as it is, it all kind of interplays with each other. That the point of expanding Medicaid was to reduce the burden on hospitals, which would then reduce charity care and dish payments. That money is still that money. It's just shifting to a different place, right? Giving states skin in the game. So, the one last piece I want to talk about is, because you do a lot of this in the policy, is these instances where people get on payment plans and then they qualify for charity care. What happens to all the money? You may have someone who might have been on a payment plan 50 or $100 a month for a year or 2 years before this kind of comes to fruition, where they may have paid out $3,000 or $4,000, in medical debt. What happens in those instances?
So timing is everything. Federal law says for nonprofit hospitals under 501R, if someone has been making payments or has made any payment and is later found eligible for charity care, anything that they've overpaid must be refunded. But the federal law also says that a hospital only needs to accept an application within 240 days from the date that they sent the first post-discharge bill, which is a mouthful. So if someone's been making payments for a few years, they're very likely past that application window. And under the federal law, I just don't. There just isn't really any hook to keep that open. We hope that hospitals will still grant charity care. We often will still apply and push for it, but very few will go down that rabbit hole with us. We did a lot of work to advocate around this issue when there was a bill in front of the Oregon legislature this last session that just passed the Senate last week. So it should be going to the governor's desk to get signed any day now. And it updates the charity care law in several key ways. One of them, it updates the state law. One of the things is it extends the payment window for 12 months after the most recent payment. So if someone has been making payments in Oregon after this bill goes into effect, after every payment extends a new 12-month window to apply for charity care. So for things like that, I mean, patients should be getting a refund if they've been making payments and they apply for charity care and they're eligible for charity care. Full stop, like federal law. We have found hospitals that are, as one on my radar right now, that we're going to reach out to, who in their policy doesn't issue refunds. That's illegal. Patients really need to push back against that. And hospitals need to stop that practice. But we're also looking at opportunities where we can advocate around this issue when there's states that are going to have some sort of regulatory activity, or there's maybe bills up where we can put issues like this on people's radar.
Why do you think the 240-day, why 240 days versus, which, I guess depending upon the number of days in a month could be 7 months or 8 months, depending on what it is, but why 240 versus a 12-month rolling 12-month calendar year from the last payment or something? Was that just an arbitrary thing that Congress put in place?
Yeah, I don't know. What got passed in the Affordable Care Act for the charity care provision in 501R really reads like a heavily lobbied compromise all the way through. I mean, it requires that hospitals have to have a charity care policy, but nowhere does it set a floor for how much they need to forgive within certain income ranges. That's just up to the hospital to set. So there's just things like that where it just doesn't really. I'm happy it exists. I'm happy it got through. I have spoken with one of the. I know the group Community Catalyst was very involved in pushing that, and were instrumental in that getting through the bill. I'm happy for that, but it could use an update to answer some questions exactly like the one you just asked me.
Yeah, no, I definitely see that happening. Well, look, Eli, this has been great. We're kind of running out of time. Everybody's got to get back to their work day because we do these during the lunch hour. So this was fascinating, and I really hope that people got a little bit of an education about what disproportionate share hospital or dish payments and how it interplays, or known as charity care. Dollar Four does an amazing job. I think that there's never going to be enough money that you'll get from donations to make this to make everybody happy. But you guys are doing, seeing the growth of Dollar Four over the past couple of years since we've been a part of it here at Advize, since Jean Marie's been on the board, has really been exponential. I really do encourage people to go on to Dollar Four's website, dollar4.org. Take a look at the website. You can donate right from the website, and make it a part of your charitable contributions. People who have the financial wherewithal and are thinking about making some donations. It really is an amazing organization. I don't know if I've ever met somebody more passionate than Jared. I don't know if Jared sleeps. He speaks frequently at these events. He's always well received. You guys are doing a great job. Eli, this was really great. I really appreciate you taking the time to educate everybody about Dollar Four. There really is a lot that can be done. And it's great to see that an organization like Dollar Four really, as a grassroots effort, has been able to do what it's done. So thank you so much for your time and effort. For those of you on this LinkedIn, we do appreciate you taking the time. If you are not getting our newsletter, you can get us at hello@Advize Health, ADVIZE health.com. You can go sign up for our newsletter. You will get copies of our weekly OIG Roundtable podcasts. You will get copies of our recordings of the LinkedIn Live. You can get us on the YouTube page that we've got, our YouTube channel. You can go up on our website, get all of this. It's great information. We're going to be putting some information in our newsletter as well, so people can click on a link and get right to Dollar Four. So as always, thanks very much for tuning in. We'll see you at the next LinkedIn Live, everybody. Eli, thanks again. Appreciate it.
Thank you.